Hi. Yeah. Good.
Morning.
Roberto gave a nice talk on radiation earlier, and then this morning at the CAT conference, and Frank talked about an interesting new study using one of those Farxiga-like drugs. I don't know if it's one of those really expensive diabetes drugs that they're now using for weight loss. And it's very interesting / promising. They're going to try for the first time, this is a new paradigm. And this is germane to all of us because I think we all have patients that might benefit from this kind of opportunity. You may recall that there have been, for 60 years, starting with amphetamines, trials looking for drugs to cause weight loss and be safe. And essentially, none of them have. Obviously, amphetamines made people lose weight, but raised heart rate, gave arrhythmias, and other un-Me Too-like side effects, which were really bad. I mean, it's an interesting / worrisome kind of history, quite honestly. And then to think that they did that in World War II, they gave amphetamines to the long-distance bomber pilots as a matter of just routine protocol, keep them awake. And so those kind of things. So it wasn't for weight loss, it was just to keep people awake. But the weight loss drugs, so there was, the amphetamines were kind of the first. Then a bunch of amphetamine-like drugs. Eventually, there are a lot of the drugs that can cause you to lose weight, like cocaine or methamphetamines or crack or heroin, things like that. But obviously, the side effects are bad. Then there was a period of time. Then there was a short period of time where there was just nothing. There just wasn't anything available in the drug form. And somebody came up with it. Norm Soler, one of the endocrinologists here in town for years, great guy, wonderful endocrinologist, was involved in some of the studies, and you will recall the leptins. They were the leptins. And we were kind of indirectly involved in some of those studies through Norm. Initially, these were add-on therapies. You do routine, good medical care, plus add this leptin drug. It did make people lose some weight, and it did seem to be maybe potentially helpful for some people. And so the study kind of went on, and then that whole kind of class of drugs that came under scrutiny because of the mitral valve prolapse issue. And there was an early signal of that kind of class of drugs causing mitral valve prolapse. Now, that was very hard to deal with statistically because, as you know, a number of people, for a couple of reasons, a number of people have mitral valve prolapse and don't know it. And it wasn't on the entry criteria for getting into that study. And so you had a bunch of people in the study, you didn't know then when you started to look at mitral valve prolapse if they had it before or if the drug gave it to them. And so it was a horrible legal conundrum. And of course they quit giving the drugs, but we followed those patients, and there were a lot of lawsuits and class actions and things like that, not against Prairie, but against the drug company, and the FDA got involved. And we ended up reading a lot of echoes after the fact, and to help the patients either clear their mind or whatever. And the truth is, the mitral valve prolapse that may have statistically been a signal. I was never totally convinced.
Wasn't that also the drug that sort of helped change the mitral valve criteria too?
That is exactly where I was headed next. Because before that, the criteria for do I have mitral valve prolapse or not was so soft, some people would say, oh yeah, that's prolapsing. Other would say it's normal, or there's a normal amount of prolapse, right? Just in the course of the valve closing, which probably there is. And so they got criteria based on that. And then people started to be more careful about calling prolapse. And then the other issue then was if you had prolapse back then, even if you didn't have MR with it, we gave them antibiotic prophylaxis. And now we don't. So that muddied the water even further. We freaked a lot of patients out. Oh, you got mitral polyps, you got to take penicillin for every dental cleaning. And we freaked them out, wasted a lot of money, and didn't help anybody along the way. So that whole weight loss story is kind of interesting. So then we had another period of maybe 5-6 years with no drugs. Everybody was too afraid to come out with a new drug having anything to do with weight because of side effects and maybe cardiac side effects. And then one of the, see this in the president of the ACC before Jeff Dove at the Cleveland Clinic, found that some of these diabetic drugs may be lowering sugar, but causing more cardiac events. And we thought we were helping people, right? And I'm going into this a little bit more detail because it raises a couple of issues, and we're talking a little bit about risk management today. And these are issues that come up to us as a matter of fact, just a matter of practice. So people were getting some of these drugs to lower sugar, and we know that normalizing sugar is good for the heart. We know that. It's good for the kidneys, good for the eyes, and in some cases, it doesn't necessarily make you lose weight, but some of these drugs did seem to have a signal, a little bit of weight loss with it, which was poorly understood. But there seemed to be an increase in cardiac events, particularly heart failure, in some of these diabetic drugs. And so one of them was a big Pfizer drug. And giant lawsuits, millions and millions of Cleveland clinics involved. And so our records, again, you talk about risk, again, this is a good lead-in. I reviewed one of those studies and for publication, and anybody that touched anything to do with the publication of those results and or the study itself, on both sides, pro or con, had all of their emails by the feds reviewed, right? Because it was a multi-million-dollar big thing. And that highlights the fact that what we document or what we say in emails is discoverable even though you delete it, right? Smart people can sneak that stuff back out. And fortunately, I hadn't said anything stupid in the email, and I had not colluded with Pfizer, and it was all good. And I was on the other side of the argument anyway. But it was scary nonetheless to have the FBI looking at all your emails. It makes you think, oh my God, what did I say to my wife last week? I mean, good or bad, either way. And the risk issue from that is that no matter what you put online, it probably, those smart people can find it if they want to. And so you're liable for anything you say online. So that is a good caveat, a good lead-in. And on the other side of the coin, the risk management, what you don't say in a patient's chart can be just as important as what you may misspeak or misanalyze or make a mistake. And we've at Prairie, 173,000 patient encounters a year. sometimes we're going to click the wrong box, right? We're humans. And so what you say, you think about some of the things we say, or maybe we made the wrong judgment out of it about a chest pain, or blame someone on heart failure. It turned out to be hypothyroidism. You know, those kinds of honest errors are, of course, discoverable. We know you're in the thing. But then sometimes when you don't say stuff, it can be bad too. And we had a lawsuit down in Carbondale out of the blue about a patient that it was a he said argument over the ER doc and one of our physicians down there at the time. And it was a classic, the ER doc said one thing, our physician said another thing. The patient ended up ultimately dying of sepsis. It wasn't even a cardiac problem, right? But hypotension is always cardiac. You know, we have to own a lot of hypotension that is not how we're doing. And so what happened, we had an ER doc saying one thing, and it actually clinically was wrong. Patient died, family sued, and our physician had said something on the order of, it sounds like sepsis, you know, get the hospitalists involved. But when the DEPS came, the ER doc said that the Prairie doc refused to take the patient. Well, the family is paying the lawyer to get the DEP from the ER doc. It reads that Prairie refused to see the patient. So now we're in the defense over a patient we never saw, died of sepsis, and we had to end up settling on that because our doc didn't document anything about the phone call. So it was a he said. The ER doc had, I talked to the cardiologist at Prairie. He said, blah, blah, blah. Didn't want to take the patient. Well, maybe he heard that. But what was meant was that send the patients to the hospitals, right? It doesn't sound like a cardiac problem. And I say that as an example of how when we're sounding like Nazis, you got to document that. You know, if somebody calls you, you need to document it somehow. It's a pain in the rear and it slows us down, I know. But there is the ideology of we've got to document something on every friggin' phone call. And this gets me so mad because we didn't really do, in my mind, we didn't really do anything wrong other than not document it. It's on a Christmas Eve, and I know the doctor was busy and wanted to get back to his family. And so maybe the only thing we did wrong was not document what he was thinking at the time. And so in terms of risk management, so these things little things can blossom and sneak up and bite you in the rear. And that's why the importance around them. And when they come up, and unfortunately, you know, we deal with about 3 or 4 suits a year, let's say, and with 115 providers and 173 1,000 encounters, it's really pretty good. But let me tell you, each one of those is awfully painful. 80% of risk lawsuits, complaints in the Midwest are frivolous and don't go beyond the threat and the attempt to get extorted money. And we try not to settle, but there comes a time if the threat is if we've got to spend $200,000 in legal fees and it's a $50,000 ask, sometimes we have to make a judgment call. And as frustrating as that may sound, at some point there are some business decisions that we have made. And I'm not proud of that. It's just that we're going to keep the doors open and we want to keep seeing indigent patients. You've got to make some business decisions like that. So I believe more now, of course, than I did in the past, how these kind of things that can be really mundane Friday morning talks, but they're important to the practice of medicine in the United States in 2018. And once you've been involved in these complaints, they would just suck the life out of you. Having a lawyer take your deb is just, you would just, it's like running a marathon just sitting there because you're scared, you're afraid you're going to say the wrong thing, and you're afraid it's going to be taken wrong. And the good news is that we have a good team of lawyers that help us, and they're seasoned. And we're self-insured through the system. Prairie pays in every year a certain amount of money. It's like $4.5 million or something like that out of our budget to go to the system. And we're self-insured. And there are a couple of good things about that, really good things. It means we're never going to lose our house because we're an entity of an organization, right? The $23 million lawsuit we had in Streeter 15 years ago that before we were incorporated with the system at that time, theoretically the doctor involved could have lost this house, right? We could have lost everything. And we prevailed on that, but it was a nasty year of crap, and that one brings up another case, another risk on my list of these kind of examples. So I gave you the example of when we had an interaction that was clinically important and we didn't document it. So we got to remember, and the physicians are going to lapse, and you all are going to lapse, and I'm going to lapse. We just got to try not to. We got to document those interactions. And this next example of a risk management situation that we can avoid, and that we would have avoided in that $23 million case, which is the most bizarre. That physician that we had that is now dead, he died in a car wreck, Riaz Namani. And it was the god-awfulest lawsuit. And I got to tell you, it was like he died twice, because it was so painful to go through that kind of legal experience. But that case surrounded what continues this day to eat my liver, which is those of us and our secretaries and our physician colleagues using the term clearance for surgery. There's no such thing in our languages, in Prairie, to ever use the word cleared for surgery. We are not God. We cannot give absolution. Nobody is at zero risk for surgery. What they are at is low, medium, or high risk. And so we are always available to help assess the cardiovascular risk in the perioperative period as to whether we think it is low risk, meaning proceed with minimal concern, or high risk, which many of our patients are. You just have to, that doesn't mean they're not going to get surgery. It just means you have to be careful and do all the appropriate things like you should. So when we assess perioperative cardiovascular risk, in the end, if it's low risk, it's not that they're cleared, it's just that we judge them to be at low risk. And that's as good as we can do. Because what happened in this $23 million case was that anesthesia, a nurse anesthetist came out of a patient that she had just put to sleep, and they were getting ready to take the gallbladder out. Right? And there was a PVC on the monitor. And she brought this, and the surgeon said, "You got to get this person cleared for surgery, or I'm not going to take the gallbladder." Of course, the schedule's stacked, and they had people to follow, and families wondering what's the delay, and we've all been there. So she comes out and hands our doctor in the hall, who doesn't know the patient, you know, "Look, this is just the PVC. It's sinus rhythm. I need, this guy's 45. I need this guy cleared for surgery." And our physician, trying to be nice, thinking he was doing a nice thing for the patient and family, signed it, cleared for surgery.
Oh, no. No.
We didn't bill for it. We didn't dictate anything.
No.
She, of course, put it in the chart, and then the patient. So why did the patient then become in hypoxic coma? It was probably not because of the PVC. Right? There was no MI. There was no heart failure. The guy had a bad reaction to anesthesia, probably aspirated, got hypoxic, and then when they and was nursing homebound for the rest of his life at the age of 45 with 2 kids and a wife, and so when they wheeled him into the hall, into the courtroom in the wheelchair like this, "See what you've done. You cleared him for surgery, and here he is." That's how you get verdicts of $23 million. Right? And then there, and we ended up settling for $1 million in hospital. I mean, it was a nightmare. So that was an example of the importance of documentation using good terms, not terms like clearance, but terms like, given the patient's risk factors and control of blood pressure, and it's on a beta blocker, and no chest pain, no active heart failure, the risk at this point appears to be low. Not unreasonable, with appropriate consent to go ahead and take this person's gallbladder out.
I see it on cardiac clearance, probably like every other NP in here. I'm always stumped by, yes, they're kind of low cardiac risk, but they have every comorbidity known to man, and you can look at this person and know that they're, this could be a bad thing.
Yeah.
So
that is an opportunity, and when they're like that, that's what gets me to moderate risk.
Okay.
And descriptors. Because this patient's had laryngeal edema in the past due to angioedema from ACE inhibitors, and because they may be atopic, I believe this person to be not at low risk. It's probably more moderate. Yet, and so this is the kind of thing you just, on the one hand, you think you may be stating the obvious,
Right.
but on the other hand, if something untoward happens, you're glad you stated the obvious.
Okay.
So now, since we're dictating and we're not, or you can type so fast, I've seen you podcast type so fast, or dictate so fast, just add that, I think this patient really is more moderate risk than low risk because of the concomitant issues of sleep apnea that's been poorly treated, the blood pressure only recently under control, and the inactivity that's led the patient can't go up a flight of stairs without breathing heavy, even though the stress test was normal.
Okay.
So those kinds of additional descriptors are always helpful. And I guess that's the point at which you can't really over-document facts.
Okay.
Because those are facts. And somebody else may get into trouble but we're relatively shielded, or we have at least a good argument to get out of that lawsuit if that patient doesn't do well with anesthesia. Patients, I've got to tell you, we have been looking at here recently anesthesia. This came up last month. In the olden days, back when giants roamed the halls, we would say somebody was too sick for surgery. primarily because of the risks of anesthesia, which are non-trivial, right? And we've become, as a group, very cavalier about, because nobody's too sick for TAVR. Nobody is too sick to have mitral clip. Those are patients that have been, many of them, turned down for surgery because they're too sick, and yet we're doing TAVR in them, and yet we're putting them to sleep to do TAVR. 20 years ago, we would have said that patient's too sick to put to sleep. And so we're trying to rethink this, because a couple of the issues we've had after TAVR, it looks to me like they were complications not from the valve or the deployment of the valve, but generally should have been anticipating complications from lowering the blood pressure through general anesthesia, right? These are sick people. Maybe we should have let them squirm a little bit and been light sedation and not put them totally out. Like in the cath lab back in the day, Jim Dove wouldn't put people to sleep. And now everybody that has a cath thinks they need to be out cold. Well, it's higher risk to be out cold, no matter what agent you use, in terms of hypoxia, low blood pressure, and aspiration. So I think we've swung too far, and we need to remember, and I'm speaking with the physicians about this next week, we need to remember that people are too sick to have surgery. We need to be really careful with their anesthesia.
Which brings up another, you remember when...
And their TE is another.
That's right. And I remember when anesthesia took the responsibility for making a clearance.
Yeah.
You know, they came up and saw the patient before, they decided, they did an H&P, and now we do that H&P.
Yeah.
Now we say, are they ready for anesthesia? That itself doesn't seem...
You're absolutely right, but I don't anticipate that we'll be able to get society to change that back. I think what my point is that cat's out of the bag. And so now we need to own it. It's just yet another thing we need to own.
Yeah.
But the truth is, here's the thing. In the end of the day, I guess I would rather own it than have somebody else not do it well. So, we don't want to. We always want to document, and then we don't want to clear, but we can assign risk, and we need to document why, and that's helpful. That's really helpful. And then we need to think about, particularly when we're doing these wild things, which are really kind of wild. Mitral clip. Come on, that's go in, snare it, pull it back, and expect it to hold, not fall out, and give a stroke. I mean, it's amazing.
Yeah.
It's not amazing that it sometimes doesn't work. It's amazing that it ever works. To me. And then I want to highlight the risk of anesthesia because we've become cavalier. And that brings up another topic I wanted to touch on. First of all, thank you for your attention, because these things are important to me. They're more important to me now because I defend every one of us every time. I defend Prairie, all of us as individuals, I'm happy to own all this, but I also need to own the importance of us to try to continue to make things better. Right? So here we are. Okay, where was I headed? Okay, so pre-op clearance, railing about anesthesia, and I think that no matter what happens going forward, Jody, to your point, I'm comfortable, and I know it's a pain in the butt, but I like it when we own the patients. If we make an honest mistake, I'm okay with owning it. But if somebody else makes an honest mistake and we get blamed, and if we could have helped, I feel terrible. So I'm okay with Prairie continuing to own the patient, you know. And so just as a policy, I mean, obviously, what he does, and, you know, but I don't want us to lose that. If you start to lose the feeling that you have responsibility and own what goes on in that patient, then you're losing, then we're becoming technicians, or scribes. There's nothing bad about being a scribe. It's just that a scribe implies that somebody else is owning the situation, which is okay, but we all kind of need to own it. So this brings up another topic I wanted to touch on, and that is the importance of informed consent. And there's a lot of literature on that, and we've contributed to the literature on this. We've had a couple cases where I think that what they call durable informed consent elements may not have been ideal. If you talk about the Me Too movement, to me the worst thing about, other than their victims, is that how do you decide who's right and who's wrong? I mean, you lose both ways. It's really, and so when I'm defending a case that Prairie Provider's involved in, and it comes up from the family, you didn't warn us about this might happen. It just crushes me, because I know we warned them that it might happen. They may not have heard it right. They may not have understood, and then that's on us. We should have explained it better. I'll own that. But make it even worse by the fact that we give them Versed and fentanyl when we do a cath, and many people with Versed and fentanyl or general anesthesia become amnestic for a period, and they legitimately don't remember. They don't remember. I do not remember what they told me before my hernia repair last year. And so to think that an 85-year-old that's having a cath is going to retain the fact that you warned them they might bleed after the procedure, and they're mad at us because they bleed, well, some people are going to bleed. Some people are going to get infected. We're doing the best we can, but it's going to happen. And we have warned them. And so they did the study, and they talked to people 6 to 8 months after a procedure. Less than half could even remember that anybody warned them about informed consent. So I say this because getting durable informed consent in cardiology when we're putting them to sleep is really hard to do. Durable in the definition was that you warned about it and they remembered, and they could say, "Oh yeah, he warned me I might bleed." Okay. So the answer to that, in my mind, is several fold. One is that we need to continue to do the best we can to be honest with people about the risks, which I think we are. We need to have compelling reasons to do something, which we do. It's not dermatology. It's life and death stuff. So we're meeting that bar. We're meeting the bar of, we warned them. They may or may not remember. And I like the multiple bites at the apple. I call it multiple bites at the apple. They may not remember pre-op that I warned them in clinic. But if the cath lab nurse does it again, if you guys reinforce, their risk, they're manageable. If stuff comes up, we'll deal with it the best we can. But you have this significant problem, and we have to approach it this way. We need to approach it this way. Then those are the elements of so honest consent, more than one bite at the apple, more than one time. And if at all possible, in front of a relative. To get durable consent on an 85-year-old, who you're going to give Versed to, you better talk to the daughter. And then, best practice, I talked we talked about the risks again. I know Dr. Shelton told them in clinic, but we mentioned it again. I answered the question, and along with the very attentive, supportive daughter. You'll see that in my patients often. They're there, they're supportive. And then, so if you get into he said, she said, daughter's upset because something bad happens, it's us versus daughter now. Patient's maybe dead or demented or something. So now it's us versus, and I've been there, us versus daughter. I shouldn't say daughter, it could be son, daughter, son, or, oh, you didn't warn us about that. Well, we probably did, right? And if there's no documentation of it, we didn't. It's like that phone call. So best practice is to make sure that we don't just get them to sign where we put an X. Doctor, here's the informed consent, right? What's this right here? This is the patient's signature saying that they consent to the procedure. What's this X here? Well, that's why I showed the patient where to sign. You mean the patient couldn't read the consent form? You had to show them where to sign? They'll never put an X on a document.
That's good.
Wow.
You've been in that
Because we always
position.
do.
I have.
Heard that.
Why did you put that X there?
They do that in
Oh, you mean the
bank.
patient understood, but you still had to show them where to sign? So you can point after you've explained the risks, but you can't put an X on it.
So what do you think about smart phrases?
Smart phrases.
We use them all the time, but are they, if somebody could document that that's your smart phrase, you just use it on everybody, doesn't necessarily mean I talked with it, just means that I pulled up my smart phrase and stuck it in my
Wow.
document.
You make a good point. I would
Yeah.
say that having a smart phrase in there is not a shield, but without it, you're toast. So without it, you just settle.
So
With it, you've at least, and like you're suggesting, now with the EHR and Epic, everything, it's all discoverable. You know,
Right.
they know when you put that in.
Right.
You put that in the day after you're toast.
Yeah.
Right.
Right? Because they can tell when when you log on, it's all in the
Yeah.
cloud. So having it is better than not having it, but is not by itself evidence of durable consent. That's why in the dictation or plan or note or somewhere, I've got, I talk to the patient. So you've got the note in there, but I would put a line, a quick blah, blah, blah. Then you got that. Then you got the piece of paper without an X. And particularly good then is I talk to the daughter. I mean, you don't even have to give the daughter a name. You can just say the daughter that was here in clinic today. And then, honestly, that's about as good as we can do.
So something personal.
Something personal is always better. And then if you get in this he said, she said, you're going to win because she didn't document it or he did. They don't have a chart. So
It's the same thing when you're doing your history and physical or your physical exam, and all you're doing is putting in the same template that you do all the time. I often wonder if that's not
I think,
also.
the templates, so we take on some risk with that. We do. And with 141 clicks for a new consult, we take 141. We've got 141 times the disappoint on close scrutiny, right? So that's why when you click them wisely, I often will click that on the general comments, on the physical exam in general. I'll go in there and say something personal, like came in with a 3-prompt, came today, going gradually downhill over the past 5 years. Well, no big deal. But that to me rises that document into the element in case I misclick irregular heartbeat, which I want to do,
I've been told by Chrissy before too that they can tell when you've copied copy forward your physical exam or your systems or even the entire note, so you have to be careful.
They can. So when you cut and paste, it's best practice to add something personal. I often will try to remember to mention, daughter. Okay, a pleasant, supportive daughter came to clinic today, and we all got to talk about the care plan. And when you put one little phrase like that in, I think that's good practice. I put silly stuff in there sometimes, like caught a giant bass last week, was very proud. I mean, it's just, and then the next year when you see them, you caught any bass. Patients love it.
Yes.
Did you catch any big bass this year?
Yeah.
It just starts you off on the right foot in clinic. And that's, and as we've said, another point, once again, I know I sound like a broken record sometimes, but another best practice is that patients and families that love us, and fortunately there are a lot of those, they're not going to sue us. They're not going to sue us. And if they, if Sally Sue, the daughter, knows that I talked about bass fishing with Dad, and that he likes me, and he bleeds after a cat someday, they know we've got no dog in the hunt of them not doing well. It's just silly to think that we want people to do well for them, So if you get over that hurdle and and they know you're trying to help them, heck, why are we here? And you personalized it, and you're treating them like humans instead of pieces of meat, then you're just not going to get sued. As long as you are honest with them upstream, you may bleed, and if you do, we'll try to take care of it. And I say things like, if it's a big deal, you just be honest. Any one of us can die today. And this is a big procedure. That's a possibility. You should use the term. You could die. Now we're going to try to make it so that you can't die, but at some point the maker calls us, and you understand that, don't you? You get a head nod when you say, at some point we're all going to get called to the maker, and whether you're atheist or Catholic or whatever, you can say stuff like that, I believe, and you're relating to the patient in terms that they can understand, and they have. It's a durable consent because you mentioned the fact that they could die. Daughter heard that. And then that little sentence, it has meaning. You all are empowered to add those kinds of comments to the chart. To me, it's so much better than that sterile 141 click, normal thing. You should probably, all of us, seek to add at least one reasonable, quirky, nice comment, and that will reduce our risk and have our patients be happier. So, there's the edgy piece about patient satisfaction, but being a metric on the system scorecard, and administrators get bonus or not get bonus based on patient satisfaction score. So there's a lot of eyes-on monthly patient sat data, and I've gotten kind of jaded about that on one level, but on the other level, well, it is important. It is for risk management. Being in a lawsuit is horribly painful. If our patients like us, we're just not going to be there. And so that means to me that there's deeper meaning to patient satisfaction than just that damn number that somebody may or may not, that Chuck may or may not get a bonus for. You know what I mean? There's a reason there.
I have a question about
Yeah.
that. So if somebody is going to have, let's say they're having a left heart cath, they have chest pain, you've explained all the risks, what exactly would you dictate?
Well, I'm okay with them getting the boilerplate thing, but in the plan, in the plan when you're typing or dictating the plan, I think that is the place to say I had the opportunity to discuss the risks of catheterization with the patient and answered his questions and his daughter answered his daughter's questions as well. Period. It doesn't have to be long, but you have, and I don't think I'd make that a smart phrase because maybe it's the son or maybe it's the grandson, and you can just put it in that day, and it's so you got the boilerplate, but you've got that line on your plan, and you've acknowledged it, and then when they come to the cath area, the cath nurses do it again, and then in the old days when it seemed like we had a little more time, I would go in before cath and do one final bite at the apple. I said, okay, you remember, here we are. We're going to go in right one if we can get in, and reaffirm it before they get their verse in. Because after that, it's moot. Because once you've given them any sedation, and legally, whatever you tell them at that point is moot. Even if they're kind of nodding, because you've seen people that are kind of drunk. Yeah, I understand. Go ahead. That's not legally. That's not going to stand up.
What about for like Meredith and I, who see a patient do the stress test,
Yeah.
have the nurse call and say you need a left heart cath, Dr. Whoever's going to do it. I generally ask the nurse to do risk benefits, but maybe that's not good enough. And then usually always Goel or Malamathu or whomever will go in and do it before the procedure. But
Yes. As many bites as the apple as you've got. I mean, if you've one of the things that, in terms of durable, one of the elements of being a durable informed consent is that you acknowledge that they had a chance to ask questions.
okay,
I answered the questions about the patient's cath today, but they'll have another opportunity to ask further questions if they come up, because they do.
I'm not good.
And sometimes looking
So
forward
just-
too, like if you know that one procedure might lead to another procedure, we'll start talking about what the next step would be. It may not get to that point, but if it does, then these are the risk and benefit of the plan B,
Exactly.
so that they've had time to think about that beforehand.
And this is, of course, the most important for surgery. And, the ones that sneak up and bite us, the ones that have been this before, haven't been, for the most part, these electives. They've been the urgent ones that we have to rush in, and the result is not what everybody had hoped, and then there's a lot of disappointment, and we didn't really have durable consent. But in the emergent situation, it is understood you don't get durable consent. You let the family member sign it, but it doesn't. It's not really durable consent, but it's the best you can do, and that's okay. It's the best you can do. We can all agree, and we're not going to lose in a situation over consent if it's an emergency. But a lot of what we do is maybe urgent, but not emergent. The surgeons have more emergent procedures than most of us in the absence of a STEMI. STEMIs are easy because there's never a question of was it needed, And if you've got a 2.5 millimeter obtuse marginal causing little chest discomfort in the mailbox for 6 months, that's not an emergency. You can try some meds and probably should fail medical therapy first. And document those things. That's good practice, because if they do then bleed and try to sue you because you had a good reason to do it. You tried medical therapy, they failed medical therapy. It was reasonable to put a stent at 2.5 millimeter obtuse marginal, from which it's very unlikely they're going to die, right? You can prune off a lot of small branches and still have a decent tree. So among the things that get discussed in risk cases is how was the procedure needed or not. And so documentation of why it was reasonable to put a 2.5 millimeter stent in an obtuse marginal is that The only reason to do that is that they fail medical therapy, unless they're infarcting. That's on the physician. The elements of informed consent apply the same there, but whether or not it's appropriate to do that at that given time, that's on the physician, not you guys. But if they're having, here's where we get into problems there. You know, angina is one thing. You know, you have angina, you don't, but it's the anginal equivalents that sneak up and bite us in the rear. We all know they're there. The number one presenting symptom for a lady over the age of 80 with a heart attack is not chest pain, it's shortness of breath. And so you can use that phrase, shortness of breath. And the shortness of breath, as you know, is hard to quantify. You know, if I ran up 3 flights of stairs, I'm going to be short of breath. Is that pathologic? Well, so you have to put some value judgments in there. This person used to get up 2 flights of stairs without any shortness of breath, but now is noticing it after 1. You know, so that's a good phrase to use, indicating the need to do something more aggressive, for example. So that's a good risk balancing phrase. Prescriptions. Our e-scribing, and we all have undergone a lot of pain in terms of getting that going and reconciliation and stuff. But the truth is, the e-scribing now, because there are limited options on a lot of things, it's really helped us a ton. It's really helped us a ton. And a couple of lawsuits we were in a few years ago can't happen now because of e-scribing. So I don't know that I need to go into that too much.
So I only have one question about the e-scribing.
Yeah.
When the screen always comes up about, you know, this interacts with this and this interacts with this, and we so often just go override.
Yeah.
So have we had any big problems with that?
It's a good question, knock on wood, not that I know of yet. One did save me a couple weeks ago. I wanted to put a guy with end-stage pulmonary hypertension on a trial of Viagra, the low dose, you know, and he was on one of those prostate drugs. It's an alpha that somebody had put on him, and I didn't even think about it. You think about nitro.
Yeah.
Mm-hmm.
Well, he's not on nitro because he's just pulmonary hypertension. So I'm thinking low dose Viagra for pulmonary hypertension in the setting of he's not on nitro. This is low risk little clinical trial, right? There's not a lot of data on it, but some people respond, some people don't. And if they respond, good, and if they don't, they just quit taking it. But it turns out that the pop-up said the guy's on an alpha inhibitor for his prostate, which, quite honestly, I didn't notice or think about it. And that saved me.
You know what's more remarkable? That you were actually in the computer doing it.
I know Tracy
in the
was.
position you were in.
No, I'd
I'd
like to take credit for that. But the computer, and Tracy saw that. And so, now that's a person who, with a PA pressure of 80 and a systolic pressure of 90, if we'd have dropped his pressure 15, he just would have arrested right there, you know, from the Viagra. And he's a prominent person in the community, it would have been really bad. So the computer helped. So I like the computer. Now a lot of them, I know a lot of them come up with the statins and the good news there is the data with statins is so awesome that almost always you're not going to get in trouble for trying a statin. You're going to get in more trouble for not trying a statin if they've got true coronary artery disease. So we're good there. The blood pressure drugs, when you get them on 4 and 5, like some are,
Yeah.
it's good then to say hedge. You know, like this person has really resistant hypertension for us for years. I know I got him on 4 drugs, but we're still not under ideal control with blood pressure. And that's a good segue into a couple of things that I also wanted to mention. We should get together more because I've got all these things I want to mention. It's kind of fun. One of our goals for next year at the system, HS system level is better control of blood pressure in our patients. And so that brings up the challenge. Well, what is better control? And so the MIPS data, you know, the Obamacare, and then there were pay for performance, and now there's penalty for lack of performance. So we got some extra money over the past few years for ticking boxes, right? And that's what helped pay for Epic, right? But now we're going to get dinged if we don't get results, not just ticking boxes. So they're making progress into what is actual pay for performance. And one of the metrics next year is going to be adequate control of blood pressure. Now we can argue a lot over what should the blood pressure be. And the answer is it depends on the patient. But in general and on average, they're going to say the Medicare criteria for the MIPS not getting dinged is 150 over 9 or less if they're over 18 and under 85. And so, and it's going to be, unfortunately, and there's no way for Medicare to do this the way we would like to do it, you know, average a bunch over a period of time. They're just going to look at the last one, you know. So we're going to have to own. So we queried Epic. We can do that now. One of the benefits, and we looked at our patients. So we said, what kind of ding are we going to get next year if we don't do anything? We just keep doing what we're doing, which we think we're doing a good job. And so we queried where we are. 67. We're meeting at 67%. So 67% of our patients are at, you know, below 150 over 90 on their last blood pressure when we saw them in clinic. And so that's our baseline. So what's perfect? Well, as you know, I don't believe 100% is achievable. So many of our patients don't even take their medicine. So the bar would not be fair if we said every single person, and then life happens. They're late, they're running around, they're cold, they nearly had an accident in the parking lot. They're freaking out, the pressure's 155. Is that they didn't take their Lasix that morning because they didn't want to pee on the way from Highland, you know? So we looked at, I think the goal should be about 75%. I think that based on the Medicare data from last year, best practice is around 75%. Now, we've got to be measuring it accurately, and we've got to train our CMAs to measure it accurately. And if we rush them in and take it real quick and let it down too quickly and say it's 155, we have to start thinking about taking it again in 5 minutes. And, you know, and in the past, tight control of blood pressure was way down on our list. We're just trying to keep the patients alive, take their statin, take their aspirin, keep them out of heart failure. So we're adding another element here. It's just that we're going to do it, we're going to shine some more light on it, work on it. It'll be better patient care. We won't get
But
dinged.
what about this? What about they come to clinic, they're 160 over 93, and so I treat them.
Yeah,
And I say, call me in a week with your blood pressures. They call me and they're 140.
yeah.
Does that data get, I mean, you know, that's there in the chart, but it's not a clinic visit.
I don't know. I think that may be part of the 25% we're just not going to, you know, that's why
So is best practice then bring them back in a week? make you see them in a week and then you've redocumented it.
I-
Once.
Ideally, that would be primary care, but we get all gored by the same horn on that, on the mix. We're lumped together, you know, with the primary care. And that's why I think our goal would be 75. And there are a lot of people who just aren't going to take it, you know, just not use their CPAP. I mean, it just, we're not going to be able to control everybody, but all we need to do is control a few more than we're doing now.
Or document, you're just talking about it needs to be documented.
I
You know,
don't
I need to
think
be able to control
Medicare,
them.
In the
I just
database
think
or
that
just in the notes?
it's not in a clinic.
yeah, I don't think Medicare is going to be savvy enough
Yeah, so
to
they
do
call
what
back with
it
the
should be
blood
doing,
pressure.
is looking at average blood pressure control, you know, not just
But you
one.
wouldn't put it in the
So instead
database.
of the nurse taking the blood pressures over the
You
phone,
could.
I need to
That's
document
what I
my own
mean.
piece plan.
I don't think we are.
And let her
But I think this
see
is
them in another clinic.
If
So I was
they're
just gonna
not
say,
in
I think
control,
if you're doing
it's
that,
a
they're
reasonable
gonna
justification for a
document it.
follow-up
You're gonna
visit.
get dinged.
It's hard for us to keep up with what we
It's not
got.
gonna work.
You know what I'm saying?
That's
I'm
why,
saying if,
Medicare's not gonna look
Yeah.
there.
if your criteria is it has to be a clinic visit,
no.
and
Can it
I'm
just be
taking them, just
documented in the
documenting them over the
database?
phone, yeah.
Now that, I
We
don't
probably
know.
need to do
I
that.
can
If
find
we
out.
Because it's not- that
document it
Medicare's not
in the
gonna look in the
database,
notes.
maybe that's good enough, I don't know. That's a good question.
Like in
Yeah.
the actual vital signs.
Yeah,
like there's a vital
exactly.
signs section with
Exactly.
it. I can talk to Nita and see if that's good.
That's a good question. Boy, that would certainly be better than,
Yeah.
They just
have
well,
a
if
floating
we take the
agreement
cap up, I'm
management
sure we take that 25.
calendar sort of situation.
I'm thinking like for me right now, if, you know, the set of vital signs that goes in that the MA does, then I check it before the visit's over. I just dictate that
Me
additional
too.
vital sign that initially appeared above goal, however on recheck
yeah.
appears reason
Needs
control,
to
but
be
that would not be
That's not
possible,
dictated.
like they're not gonna pull
That's a
that
best
data,
practice. What we have to ask Maida is when Medicare queries, what will they see?
They'll
Yeah.
probably only see what's entered in the vital signs section.
So we need to
Then,
enter the
then if
best
it's,
one.
if we met goal after the initial visit, then we need to change.
I wouldn't say you necessarily even need to change the blood pressure, you can just add another one and then that'll be
So
consistent.
transfer.
Yeah, well, that would be good.
Yeah.
Because they're both, they're,
I need to do
we're gonna assume they're both correct.
Right.
And, I think that's the way. So anyway, then I want to finish up maybe, bear with me just another minute. What I've got is another thing that we're going after, which is really kind of exciting in a way, if you get excited about these things. But Amy Duraco is leading the CT surgery target bundle. We're going to be in a voluntary Medicare bundle payment model. And this is, we talked about, those of you who may remember, I've been talking about this for 10 years. We're going to be bundled. We got to prepare for being bundled. Well, finally, we're going to be in a voluntary bundle as right away. And in devices and coronary bypass graft surgery. And so we've done an agreement with Medicare that if we do these coronary bypass graft surgeries and our costs are less than target, Medicare is going to save some, and then they're going to kick us back some. And we need that for operations. And it's better care. It's better for the patient. So we've got a number of things you'll be hearing about along the way that we're going to be doing with the apps following the patient and calling them and bringing them back in clinic to see them quicker. These bundle patients. Now the good news is that there are two really good things. One is that we have a consultant company that's helping us with that, and we're paying them to help us because that's cheaper than doing this all by ourselves. But the consultants looked at the baseline data, and we're already looking very good compared to other sites. So we'll get, even if we don't do anything different, we're going to save a little money. Okay, and that's good. And particularly with the patients, a lot of them having high deductible plans and percentages they have to pay out of the pocket. If we save money, it saves the patient money too. It's not just us, right? So it's a good thing to do. So if we save a little more money than we're saving now, then we'll actually see some of it come back And so that's cabbage. We feel pretty good about that. We got a lot of nice strategies. Amy's going to be, she'll be talking about things. And we're meeting with the consultants again next Thursday. So that's the bundle. And then the device bundle. The device bundle is the same. And we're going to win on the device bundle because we've beaten on the, quite honestly, Greg Mishko beat on the device companies to lower their prices. And so we're paying less than a lot of the comparators. And so we're going to save money because they beat on the companies, which is good from my perspective. And then we're going to only put in certain companies' devices if it makes sense. And so that's going to be the device bundle. And I anticipate that we will be successful on that. And these are voluntary. We could have volunteered for a stent bundle, but we decided not to this year. We're going to do these 2 pilots, which there's a lot of work that goes into these things. We do these successfully, then we'll take the lessons learned from that and do a stent bundle. Now, we would have been successful at a stent bundle here, but not a couple of our other ministries because we just don't have the infrastructure. We've got more infrastructure here in the cath lab than we do in a couple of our other ministries. So that data was not as good. And we didn't want to put a ton of effort into it and then fail. So I think in a year we'll revisit that decision and probably be doing the voluntary stent bundle. And this is our contribution, not just to ourselves to get some rebates, but the patients, because their out-of-the-pocket will be less, Medicare will be spending less in the aggregate. And if we don't do those kinds of things, and we've been setting up to do this, we've been talking about doing this forever, so we're finally actually going to do it. Okay, so that's cool, I think. And the other cool thing is our main competitor in the West, Barnes, predominantly, in so much as they're at some point going to own Memorial, maybe DMH, and they already own Belleville Memorial. They're a real competitor for us in the West. They are horrible at their expenses per case. They're just horrible if you look at their data. And so they're starting out up here. So it's going to be harder for them to bring that down to our level. So competitively, then we'll be able to take that data to Blue Cross Blue Shield and say, in Southern Illinois, give us your coverage for those patients preferentially over those darn people at Barnes who waste money. So that's the strategy. That's the strategy. So, okay, we should probably talk some more in a month or so if you want. We could do that. We could give some Farmhouse a call and stuff like that. I love you guys, and there's a lot of good going on, and there's a lot of good on the system side too. I would the deaths from sepsis in the system are less than half expected in the nation. I mean, that's because they've rolled a lot of effort on the nursing floors and with the hospitalists on getting up to speed on best practices on sepsis. So Prairie's, we've always prided ourselves in doing a lot of good things, and we always have, and we continue. This is what we're doing. We're continuing these things. But HSH's medical group is starting the same thing, and I like to tell them, of course, I tell Melinda, the head of the medical group, she's fabulous, Melinda Clark, we'll get them prairied up someday, and we're trying.
In neurology too.
That. Neurology, you're absolutely right. We're going from no neurology to a neurology team, doing good stuff, improving results with stroke, which, God forbid, you never want to have one of those. And that's good. So there's a lot of good going on. And so I want to end with a lot of good going on, because when I start out talking about lawsuits and risks, you end up wanting to suck a gun barrel. But the good news is that that's not all of what we're doing at Prairie. There's a lot of good, and you guys are involved, and I appreciate your help. Fair enough? Now get to work.
So what